It's a great honor to me to be here. I'm Koji Kaneoka from Japan Swimming Federation, and I will talk about prevention of lumbar injuries in diving. During competitive diving events, impact forces are very large at the water entry phase, and therefore divers experience a lot of physical stress. We investigated lumbar spine morphological changes of 39 elite divers. Our MR images revealed 44% of divers with lumbar disc degenerations, whereas Branto reported 65% previously. And our X-ray images revealed 25% of divers with spondylolysis, which was previously reported as 43% by Bodo. We also found that 31% of divers had scoliosis with angulation of more than 5 degrees, and that 56% of female divers had scoliosis. 16% of the divers' scoliosis angles were over 10 degrees. We speculate that at the moment of water entry, large impact force applied to the entire spine, and that this compression load forces the spine to cause a so-called buckling motion. As a result of this repeated motion, growth at the end plate is inhibited in the compressed side and accelerated in the distracted side. This may be the cause of the gradual progression of scoliosis. And we conducted injury surveillance in 116 elite divers during national training camp. And the injury was defined as musculoskeletal problems caused by diving activities, which made divers take more than 1 day of rest within a year. Injury prevalence was 66%, and 77 divers sustained 112 injuries. The most frequent injury was lumbar region, and 43 lumbar problems occurred, meaning that more than 1/3 of them experienced low back pain, which affected their training. And most of these divers had extension type low back pain, which occurred during the entry phase. There are several types of low back disorders, such as intervertebral disc problems, facet joint pain, muscular problems, and sacroiliac joint pain. Facet joint pain and spondylolysis, which is a stress fracture of the lamina, are usually caused by lumbar extension motion, and these types of low back pain are generally exacerbated during lumbar extension motion. There are two methods to enter the water surface. One is a forward entry after forward rotation, and the other one is backward entry, which dive to the water surface after backward rotation. At the entry after backward and reverse diving, lumbar spine suffered from extension force that results to the facet joint compressed load. We think these forces cause the facet injury and lead to low back problems of divers. I will show a case report of a diver who suffered from a facet injury. He dived backwards from a 3-meter springboard, and at the moment of the entry, his lower back was forced to extend. Immediately after the dive, he suffered low back pain. His back pain exacerbated when he extended his back, and he had local tenderness on the 5th spinous process and left L4-5 facet joint. An axial STIR MR image revealed high signal intensity change around the L4-5 left facet joint. We have previously investigated possible risk factors related to low back pain from physical and technical characteristics in elite junior divers. 83 divers were included in this study. Low back pain was assessed by a questionnaire, interview, and physical examinations during a national training camp. Morphological data, physical fitness, and diving skills were also evaluated. For these divers, we evaluated shoulder flexibility using shoulder rotation widths. Divers stood with their feet shoulder widths apart, holding a rod with their arms extended. From that position, they were asked to rotate their arms backwards over their head without bending their elbows. The minimum distance between their hands at which this movement was possible is defined as shoulder rotation widths. The factors related to low back pain were extracted by using logistic regression analysis. As for the results, shoulder flexibility and age were recognized as factors related to low back pain in male divers. This result suggested that shoulder flexibility is important for preventing low back pain. This led us to consider that limited shoulder flexibility could cause lumbar hyperextension. To prove the hypothesis that shoulder joint angle at the entry affects lumbar extension angle, we investigated the influence of the shoulder angle at the entry to lumbar alignment. 12 male elite divers participated in this experimental study. They performed a 201B dive, as shown in this video. Diving motion was filmed laterally using a high-speed video camera with 200 frames per second. The shoulder and trunk angles were calculated at the entry phase, as shown in the figure. And this diver is one of the best divers in Japan. This figure indicates the relationship between shoulder joint angle and the trunk angle at the moment of entry. As shown in this figure, the shoulder angle increases as the trunk extension angle decreases. If the shoulder flexibility is low, the lumbar spine is forced into a lordotic position at the water entry and may cause lumbar intervertebral segmental extension motion. Hence, it is important to keep their shoulder flexibility high to prevent extension-type low back injuries. And another risk factor for low back pain may be trunk stability at the entry point. Because of the unstable structure of the lumbar spine, the trunk muscle have an important role in maintaining stability. There are two types of trunk muscles, the superficial muscles and the deep muscles. These muscles complement each other and give stability to the lumbar spine. A global muscle connects the thoracic cage and the pelvis and produces the large power necessary to move. However, it cannot control lumbar segmental motion. During a thorac-pelvic motion using the global muscle system only, segmental instability to the lumbar spine may occur. External oblique, rectus abdominis, and erectus spina are categorized as the global muscles. And I think the global muscles are well developed in divers compared to competitive swimmers. Deep trunk muscles, or the so-called local muscles, connect the lumbar vertebra directly, so they can control segmental spinal motion and provide stability and postural control to the lumbar spine. It is considered that the deep muscles and fascia of the trunk form a musculofacial corset-like system, and that trunk muscle dysfunction leads to musculofacial tension imbalance, which cause low back disorders. During trunk motion, the local system works and gives stability to the lumbar spine prior to global system activation. It is considered that this coordinated motion is important for stable trunk motion. If the local system does not work properly during sports activities, lumbar segmental instability may occur and cause intervertebral disc disorders and facet pain. And global muscle hyperactivity, on the other hand, may lead to musculofacial pain, muscle-bone junction problems, so-called entetopathy, and trunk muscle strain. We believe that all of these pathologies are caused by stabilizer dysfunction. From a muscle stability point of view, we speculate that if junior divers do not have enough local muscle function, and if the global muscle system needs to work too much instead of the local system, the thoracic and lumbar spine cannot maintain a straight alignment, leading to scoliosis. I suppose these extremely well-trained divers have excellent trunk muscle function. Therefore, if shoulder and hip mobility and trunk stability function is decreased, segmental hyperextension may occur, especially at the entry of a backward dive and cause facet injury. Thus, it is important to maintain shoulder and hip joint mobility and trunk stability function to prevent extension-type low back disorders. And besides the extension-type low back disorders in divers, intervertebral disc problems are often found in competitive swimmers. We experienced 5 swimmers whose competitive performance decreased at an international competition due to discogenic pain. In order to prevent these low back problems, our medical committee developed an injury prevention program which consists of stretching and trunk stabilization exercises. This program is demonstrated at several training camps for top-level swimmers, and we expect this program to improve their competitive performance as well as prevent low back pain. This table showing injury surveillance rates before each Olympic and Asian Games clearly indicates that the prevalence of low back pain decreased from 30% at 2002 to 11% at the Rio Olympic Games. And it is considered that trunk stability can enhance athletes' competitive performance because athletes often suffer several types of disturbances in their competitive activities. In this video, swimmers perform stabilization exercises during pre-competition camp and also just before competition to improve their stability during the race. However, it is not clear whether these exercises are effective for competitive performance. So we investigated how stabilization exercises affect starting performance immediately. The intervention of this study was on exercises as shown on this slide. They are almost the same as we used in London Olympic Games. We measured entry distance, which is the distance from the wall to the finger entry point. The time to reach 5 meters, and also measured the velocities at the entry and 5-meter points. And we compared them between pre and post of the intervention. This shows the result, and the entry distance did not change after the intervention. However, the time to reach 5 meters decreased from 0.829 to 0.810. The difference is only 0.019 seconds, but it was a significant change statistically and may be meaningful to swimmers. Please take a look at this video. It shows the final race of 200-meter butterfly in Rio Olympic Games. Michael Phelps takes the lead. And he touched very well. And the Japanese swimmer got second place. And the time difference between gold and silver was only 0.04 seconds. And this silver medalist is a student of my university, and he knows well about this significant change. We calculated the deceleration rate from the velocity change between the entry point and the 5-meter point. This result indicated that the deceleration rate significantly decreased after the intervention. These results indicate that stabilization exercises increased trunk stability at the entry phase and may have maintained their velocity during the entry phase when large resistance is applied to the body due to water entry from the air. Our other intervention experiments showed that these stabilization exercises decreased the swimmer's lobar lordosis angle, and the velocity was maintained during the underwater streamline position after kicking off of the wall. In conclusion, we think these injury prevention methods may at the same time be the solution for enhancing performance. Thank you very much for your attention.